All right, quarter past the hour, let's get started. So welcome everyone, thanks for joining us. My name is Elise Hoover. I'm the hospitality host for this session. As I mentioned, this is Beyond Kidneys, How PKD Affects Your Body. I'm really pleased to introduce our speakers for this session. Dr. Terry Watnick is the Joan B. and John H. Sadler Professor of Nephrology at the University of Maryland School of Medicine. He previously served as the chair of the Foundation Scientific Advisory Committee and was also a member of the Board of Trustees. Here as well is Dr. Michael Mrugh. He's a professor of medicine in the Division of Nephrology at the University of Alabama at Birmingham, where he trains the next generation of physicians and scientists. Dr. Mrugh currently serves as the chair of the Foundation Scientific Advisory Committee. And then also joining us is Dr. Neera Dahl. She's a clinician educator and an associate professor at the Yale University School of Medicine, section of nephrology. Dr. Dahl is also a member of the Scientific Advisory Committee for the PKD Foundation. Doctors Watnick, Mrugh, and Dahl, it's my pleasure to turn the presentation over to you.
Yes. Okay, great. So I just want to thank everybody for joining this session. Looking forward to it. So I'm going to be talking about aneurysms in autosomal dominant polycystic kidney disease. And here's an outline of what I'm going to be talking about. I'll just want to brief, everything is brief. I'll talk about what an aneurysm is, about aneurysms and PKD, screening, and then briefly mention treatment. So what is an aneurysm? An aneurysm, shown here, is a localized weakness in a blood vessel wall. And when that happens, you get ballooning and dilatation of the vessel. And so there are two main types of aneurysms. The first is intracranial aneurysms, or an aneurysm in the artery of the brain. And most of these actually occur in what is called the circle of Willis. Is this little part of the brain vasculature shown here, and it looks like a little circle, which is why it's called the circle of Willis. And so my talk is mostly going to focus on these type of aneurysms. The second type is those aneurysms of the aorta, and the aorta is the main blood vessel in the body, but I'm not going to be saying much about those. So it turns out that aneurysms are more common in autosomal dominant polycystic kidney disease in comparison with everyone else. And so I'm showing you here a little bit of a busy slide, but in this slide, all of these different authors just screened everyone that they saw with polycystic kidney disease. So I just want you to focus here on this column. So when they screened all comers, this is the percentage of people that they found who had intracranial aneurysms, okay? So it's somewhere on the order of, let's say, 9 to 12%. So the incidence of intracranial aneurysms in the general population is only about 2%. So you can see this is about 4 to 5 times the risk. If you then look at the rate of aneurysm in those people with PKD and a positive family history of aneurysms, you can see that all of a sudden that jumps to somewhere around 20%, which indicates that having a positive family history is a very important risk factor for developing aneurysms in polycystic kidney disease. So why do we care about these intracranial aneurysms? The reason is because they can rupture or burst. And so when an intracranial aneurysm, an aneurysm in the brain ruptures, because the brain is a closed space, it results in what we call subarachnoid hemorrhage, or blood in the brain. And this can cause significant and lasting neurologic impairment. So if we were to be able to detect that early, then it could be monitored or treated. So it's very important to find these early if you can. So what do we use to screen for intracranial aneurysms? And here we're talking about pre-symptomatic screening, which means you don't know whether you have one or not. You may have some risk factors. And so the first method I want to talk about, which is the method of choice, is what we call magnetic resonance angiography, or MRA. And that's different than just an MRI of the brain. This is a very sensitive method. It'll detect pretty small aneurysms on the order of 3 to 5 millimeters. 3D time of flight, or 3 Tesla with a 3 Tesla magnet, which is a stronger magnet, has more than 95% sensitivity in picking these up. And we like this method of screening because it does not require any intravenous contrast. The disadvantage of this method is that it's contraindicated if you have certain metal devices in you, and the most common one is a pacemaker, or if you're claustrophobic. So for anyone who's been in an MRI machine, it can be a little claustrophobic, but because of its sensitivity and the lack of a need for contrast, it's the method of choice that we're using for screening right now. The other main method is what we call CTA or CT angiography. This is also very sensitive, but the problem is that it requires iodinated contrast dyes, which, as you know, can have an effect on kidney function. So this is less preferred. If you find out that you do have an aneurysm, or if there's some question on the screening study, what's called a digital subtraction angiography might be recommended. And this is kind of similar to a coronary angiogram, where they go in through either the groin or the arm and they use dye. It is the gold standard. It's the most sensitive. It can be used to better define the anatomy of the aneurysm, but then, as I said, the disadvantage is it uses iodinated contrast, and there's been some literature to suggest that it may have a higher incidence of complications in individuals with PKD. So this is not recommended as a screening modality at all, but if you are found to have an aneurysm, or there's some question on one of the two other studies, it may be recommended. So the main question, so who should be screened for an aneurysm? And there's a little bit of debate, but I think most experts do not recommend screening everyone. So who do we screen? Those people who have a family history of someone else in their family with an intracranial aneurysm or a bleed. So as you saw in that table, those are the people who are really at increased risk. If you've had a previous aneurysm rupture, obviously you're at risk and you need to be followed. If you are in a high risk profession, like the classic one that's always cited is like an airline pilot, where if you had an aneurysm rupture, it would put the lives of a lot of people at risk. Or we also screen people who are anxious about their risk for whatever the reason. There are some experts who also recommend screening people who have no family history of PKD, or if they have an incomplete family history. And finally, at many centers, those individuals who are undergoing major elective surgery, like kidney transplant, a liver resection, or cardiac surgery, are also screened. This is what I think most people agree to, but there is another group of people who, based on cost effectiveness analysis, screen everyone and then just repeat the imaging at 2 to 10 year intervals, depending on what risk factors they have. So what happens if you're found to have an aneurysm on one of those screening studies? So the first thing I want to say is that these kinds of management decisions about what happens should really involve a multidisciplinary team. Okay, so as a nephrologist, I don't think that I would be the one to decide how it would be treated, but I definitely have a role in terms of weighing in. So the team should include a nephrologist, a neurosurgeon, and or an interventional neuroradiologist. And what are the treatment options? They include, if the aneurysm is very small, observation with serial imaging studies to make sure that the aneurysm doesn't change in size, surgical clipping, what we call endovascular coiling, and basically everyone should have a lifestyle modification. So how do we decide what to do? Well, first you want to weigh what are the risk factors for the aneurysm rupturing. If it's not going to rupture, it's at very low risk, you might want to follow it. However, if it's at high risk, then you would want to intervene. So it turns out that most aneurysms are asymptomatic until they rupture. And the data for these risk factors primarily comes from the study of aneurysms in the general population rather than only people with PKD. So cigarette smoking, for example, is a big risk factor for aneurysm rupture. And in the general population, the risk is about 3 to 4-fold. Alcohol consumption, poorly controlled high blood pressure, and then there are a number of risk factors associated with the type of aneurysm that you have. So for example, the risk is much smaller if the aneurysm is small and the cutoff that's used is less than 7 millimeters. If it's in the anterior circulation, so I showed you that little circle of Willis, so the anterior part of that is at a lower risk for rupture, and the posterior circulation is at the highest risk for rupture. So just a few words on treatment. The first modality that I kind of had on that list is surgical clipping, and that is shown schematically here. So what that means is that they put a metal clip along the neck of the aneurysm, and the clip stays in place. So this is it's an invasive procedure. It involves a craniotomy, or they have to actually get into your brain. So clearly this is going to have more complications. The second method I'm going to mention is what we call endovascular coiling. And this doesn't involve a surgical approach, but an angiographic approach. Okay, so they go in through the groin or the arm, just like you would for a coronary angiogram. And I'm just going to show you what that might look like here. So right here at the tip of this arrow is a big aneurysm. And what you do is they put like coils into the neck of the aneurysm, and this eventually obliterates it, obliterates the hole there. And that's what it looks like after it's obliterated. This one, you can see that it's gone. And so this type of procedure has lower morbidity and mortality, and I think it's playing an increasing role in the treatment of these aneurysms. But I will say that this is a really rapidly evolving field, and people are getting a lot of experience with these methods and tweaking them, and they're getting better and better with time. So the therapeutic approach, or which of these is chosen, depends on the size and the location of the aneurysm, the general health of the individual. You have to weigh the risk of rupture versus the risk of intervening, because as with any procedure, there are always side effects. And again, as I said, this is really best decided by an expert team, including all those individuals that I mentioned. And then you definitely want to get treatment in the center who has a lot of experience and is very versed in these kinds of methods. And then, of course, lifestyle modification really should be implemented for everyone, regardless of choosing any of these other modalities. And that means smoking cessation, treatment of hypertension, and treatment of cholesterol issues with a statin. So this is a question that comes up a lot, like, so what if you get screened and the MRA is negative, then what? Okay, so the data that I'm showing you is I think the main study, that the only one that I could find, and this was done by Robert Schreier at Colorado, where he looked at 76 people with PKD who had an initial negative screening study, and then he repeated it at 10 years for everybody. And in that group of individuals, he only detected 2 new aneurysms. So it's a very small rate. One was there in hindsight when they looked back, and there was only 1 individual who had several new aneurysms. And this person was in a high-risk group because they had a positive family history and a significant smoking history. So I think what we'd say is that if you have a negative study, rescreen. If you're at high risk, somewhere at the 5-year mark. These authors recommended 5 to 10 years. I sometimes do it a little sooner. And so I'm going to end there and pass this on to the next person. Thank you very much.
So I would like to thank the organizers for inviting me and participants of this section joining the section. I'll just continue. Here are disclaimers, my disclosures. I will continue with the cardiac manifestations in ADPKD. And the objectives is to cover basically ADPKD related cardiac complications, such as heart valve abnormalities, coronary artery abnormalities, and the cardiac hypertrophy. So cardiac manifestations in ADPKD obviously include the heart. And let me start with reviewing how the heart works. So heart is basically a pump, actually 2 pumps. One right heart pumps the blood into lungs, and the left heart into the body. And how it happens. So the blood comes to the heart through 2 main veins, the inferior vena cava and superior vena cava. It mixes up in the right ventricle, and it flows through a valve called tricuspid valve into from the atrium to the ventricle. And as the heart squeezes, the increase in the pressure in the ventricle closes this tricuspid valve and opens up the pulmonary valve. And blood from the ventricle is then ejected through that pulmonary valve into the pulmonary artery and into the lungs, where a gas exchange occurs, and then oxygenated blood returns back through pulmonary veins into the left atrium. And from that left atrium, it goes through a valve called mitral valve into the left ventricle. And again, as the heart squeezes, the pressures inside the ventricle increase, will shut off the mitral valve and opens the aortic valve. And then the blood is expelled through that aortic valve into the aorta and the body. So the valves are critical for appropriate function of this pump, the same way as is the muscle itself. And this is how it works. You know, if you sort of look at it, this is in an animal. This is the chest wall. This is the heart, and you can see this gray part is the cardiac muscle. Here, right atrium. I'm sorry, left atrium, and this is the left ventricle, and this is aorta. And we have the mitral valve here, and it opens up and now closes, opens up and closes, and the blood is ejected through an aortic valve here. And again, it says ejected, opened up, closes, opened up, closes. So in patients with autosomal dominant polycystic kidney disease, abnormalities in heart valves can be found in 25 or 30% patients. Most of them involve mitral valve prolapse, that is from benign condition. What does it mean, mitral valve prolapse? So under normal circumstances, that mitral valve that I showed you closes nicely and tightly. There's no flow through it, and leaflets are sort of nicely joined. There's no substantial movement of these leaflets as the blood is being ejected through the aortic valve when the pressures increase in the ventricle. Now, in the mitral valve prolapse, as the pressure increases in the ventricle, it pushes the leaflet of the mitral valve into the left atrium. But there is no leakage of the blood back to the left atrium. If it happens and blood is regurgitated back into the atrium, we call it mitral valve regurgitation. And similar defect may occur in the aortic valve, and we call it aortic regurgitation. Now, what people may feel if they develop these conditions? Well, for mitral valve prolapse, most patients are asymptomatic, and they may even not know about it. Some may develop attacks of palpitations, anxiety, or lightheadedness. Patients with mitral valve regurgitation may develop palpitations, but also swollen feet, shortness of breath, fatigue, depending on the severity of this regurgitation. And with aortic regurgitation, it's similar, but these patients may also have chest pains, fainting, irregular pulse. So as I mentioned, these abnormalities of heart valves in ADPKD are mostly asymptomatic, such as in the case of mitral valve prolapse. But in some patients, the symptoms may develop suddenly, while in the others, it may take decades. If a significant regurgitation occurs, then surgery is often required to repair or replace the valve. And the repaired or replaced valves increase the risk for endocarditis or inflammation of the lining of the heart muscle. So for those patients that are in risk, we consider antibiotic prophylaxis. What it means, basically using antibiotics before scheduled procedures to reduce the risk that the bacteria may infect that lining of the heart. However, this prophylaxis is recommended only in patients that are in highest risk for this complication, and it includes the patients that have prosthetic valves or valves that were repaired with prosthetic material, patients that have prior history of infective endocarditis, or those that have major congenital heart abnormalities. The high-risk procedures are dental procedures, that includes the cleaning, and then the procedures on the respiratory tract. Antibiotic prophylaxis is not generally recommended for patients with moderate risk conditions, such as mitral valve prolapse, even if there's some regurgitation, and then acquired valvular dysfunction, such as mitral or aortic regurgitation. So the next complication is the coronary artery abnormality. And these abnormalities are rare, but can be serious. And most notable are the coronary artery aneurysms. This is what I'll cover. So coronary arteries, they stem from aorta, and they run on the top of the heart muscle and supply blood and oxygen to the heart muscle. And normally they are sort of straight, but in some patients, and this is increased in patients with autosomal dominant polycystic kidney disease, these arteries may develop these dilatations, like widenings, and sometimes it may be symmetrical. In some other cases, they may develop true aneurysms, like in the brain, these saccular aneurysms. And in both of these cases, the blood still may flow freely through the main vessel stem, and these patients may be asymptomatic. But really dangerous situation is if under the pressure, the wall of that blood vessel, or actually its inner layer, ruptures, and then the may flow into this newly created cavity and dissect that blood vessel in between the layers and basically fill the space with the blood. And then it pushes back basically that inner layer of the blood vessel into the original lumen and obstructs the flow. And the results may be symptoms that resemble a heart attack. So dissection equals emergency. It may manifest with chest pain, fatigue, pain in arms, shoulders, jaw, shortness of breath, sweating, nausea, dizziness, like with a heart attack. Okay, so final complication that is seen in the heart with ADPKD is a change in the size of the cardiac muscle, which is increased, and we call it cardiac hypertrophy. Previously, it used to be common, but its frequency is changing as patients are being appropriately treated, because this appears to be a treatable condition. So seminal insight into how it can be appropriately managed came from a HALT PKD study. Some of you may have participated in this study. And that study, part of what it tested was looking at the effects of standard blood pressure control, like 130/80, versus a very aggressive blood pressure control when looking at blood pressures less than 110/75. And it has shown that with standard blood pressure control, the size of the heart muscle is coming down to get closer to normal, but this process was accelerated, and that getting closer to normal heart size was becoming faster when the blood pressure was more aggressively controlled. So this is why the current recommendations for blood pressure targets in patients with ADPKD are less than 110/75, that a lot of primary care physicians may not know about. If the patients are in age 18 to 50 years and their renal function is relatively preserved with GFR more than 60. For everybody else that doesn't fall into this category, we consider blood pressure target less than 130/85. So in summary, abnormalities in ADPKD are common, but they are mostly benign. However, severe regurgitation may require surgical management. And in most ADPKD valvular complications, antibiotic prophylaxis is not recommended. Coronary artery abnormalities in ADPKD are relatively rare, but potentially serious, and it's important to know about them. And then ventricular mass is increased in patients with ADPKD. However, it improves with aggressive blood pressure control, and this is why we suggest for young patients or moderately old patients to have the blood pressure target 110/75 if the renal function is preserved. You can find more information on this topic on the PKD Foundation website. Here is the link for an outstanding resource. And that's all. Thank you.
Thank you, Dr. Murag. And now Dr. Dahl.
Okay. All right. As Michael said, thank you all for inviting me. I'm very excited from a foundation standpoint. We didn't know how the virtual meeting would go, to see that there are 116 people logged on at the end of a long Friday. So I really am excited about that as well. My topic is going to be talking about complication of liver cysts. And so let's jump into that. So liver cysts are common in ADPKD, and the way the liver cysts form, so the liver is here, the biliary system is in green here, and then this is part of that, that's the gallbladder. And so this is making bile acids that are important in the digestion for digesting fats. And what you see forming here are cysts. So the idea is that that there may be a little bit of a rest left over, and then that in time there can be fluid secretion into that, and formation of a cyst that then is completely separated from the rest of the biliary tract. And there are two diseases that look very, very similar in that they both cause both kidney and liver cysts, but they're important to define because of what I'll show you. So the disease that most patients have is ADPKD, or autosomal dominant polycystic kidney disease. And this, as you all know, causes cysts in the kidneys and with bilaterally enlarged kidneys. The liver expression can be very variable. So some people may have a few cysts, some people may have many cysts, and then some people may have true liver cyst and liver enlargement from having many, many very large cysts. And in this disease, in ADPKD, kidney size or total kidney volume determines the risk of progression. And I'm sure we'll hear more about that throughout the meeting. And in this disease, 75% of patients develop kidney failure by the age of 62. And so we really have put a lot of emphasis in thinking about the kidney failure aspect of this disease. It's caused mostly by a mutation either in PKD1 or PKD2, with another very rare mutation causing both a PKD and a PLD phenotype. The other disease, and this is sort of the mimicking disease, but this is called autosomal dominant polycystic liver disease. And the presentation can be similar in that there are enlarged kidneys and liver. However, in this disease, the kidney disease may progress slowly or not at all, and kidney failure is rare. And this disease is caused by mutations in genes that are involved in protein processing. And for those of you who come to the longer talk tomorrow, I'll talk about that aspect a little bit more. But it's important to just know which side of this you're on. And for most people, it will be this side, the autosomal dominant polycystic kidney disease. And for the rest of the talk, what I will talk about is what ADPKD looks like in terms of liver issues. So here, what you see is as folks get older, so this is age 15 to 24, this is age 25 to 34, and then 35 to 46, you can see the women progress a little bit faster in that there are more liver cysts at an earlier age in the women compared to the men. But in this mid-adulthood range, 35 to 46, 95% of women, 93% of men have at least some liver cysts. And so here I'm just showing you some representative images. These are MRIs. And if you haven't seen a lot of these, the bright circles are the cysts. So what we're looking at here is a liver image, and then this is the kidney. So that's one kidney, this is the other kidney. And this person has mild disease, so a few cysts in the liver, a few cysts in the kidney, but otherwise relatively preservation of both organs. This person has severe kidney disease. You can see a lot of cysts in the kidneys, but the liver looks pretty good. There aren't a lot of cysts there. This is a person who has a lot of liver cysts, but all of these cysts are fairly small, and the kidneys look pretty intact, only maybe a cyst in each kidney. And this person has an enlarged cystic liver, so multiple cysts diffuse throughout the entire liver. You can see this liver is quite enlarged compared to this liver. And the kidney is enlarged. The one that you can see is quite enlarged as well. So the disease expression for ADPKD can be quite different. And they look to see, was there a clear link between the liver cyst volume and the kidney volume? And as you can maybe guess from these 4 images, there isn't a clear correlation there, in that we know that total kidney volume can drive who progresses to end-stage renal disease, but the correlation between kidney and cyst volume was not seen in the CRISP cohort. It is seen in another cohort in women, but did not stand up when we looked for age in those. So what happens with having the liver cysts, excuse me, and what happens? How do liver cysts impact function? So this study was looking at those people with mild polycystic livers compared to moderate, compared to very large polycystic livers. And here you can see that the people with the most severe disease tend to be a little bit older, that really with the severe disease, these tend to be women. So by the time we look at the folks with severe disease, defined as a liver volume that's greater than 1,800 mils per meter, most of these patients are women. And the take home here is that for the severe disease, these are likely to be older patients, more likely to be women, and some had more loss of kidney function. So if you look at the GFR, you can see as you go across the time course, there's some loss of kidney function, but still pretty good. This is 84 mils per minute. And the different groups had similarly sized kidneys, but the ones with the severe liver disease had larger spleens. And the good news here was that they reported minimally worsening quality of life. And some of you may have heard one study that was done many years ago looking at estrogen that was given as hormone replacement therapy for postmenopausal women. And in that study, it seemed that the estrogen exposure correlated with growth of liver cysts. And so based on that one single study, the teaching has been to tell women to avoid exogenous estrogen, either in the form of an oral birth control pill or as hormone replacement therapy. And the more modern look at that data comes from a retrospective analysis of one of the HALT studies. And here what they found was that there was no real difference in liver volume by oral contraceptive use. Women with pregnancy had larger livers, excuse me, that should be livers, but this difference was not significant when adjusted for age. So I think that we still talk to women and counsel women about using exogenous estrogen because of the risk for permitting growth of the liver cysts, but we talk about that in maybe a different way than we had previously. So if we look at those patients with mild liver disease versus moderate versus severe, what symptoms, what are people complaining about? So what you can see as the liver gets bigger, they're complaining about early satiety. This means feeling full before you've eaten a full meal. So you take a few bites and then maybe you feel full then. You might have a lack of appetite. This problem's just because of size of the organ, dissatisfaction with abdominal size. A lot of people feel, especially with the liver cyst being right under the rib cage, that can cause a fair amount of difficulty with dressing and things like that. Some tiredness, limited mobility, shortness of breath, and either abdominal pain or pain on the side or pain and pressure on the rib cage. And definitely there's a correlation here with the liver sizes getting bigger. And this is another study looking at similar either complications or symptoms. The symptoms people are mentioning here are back pain, flank pain, right upper quadrant, so right under the rib cage pain. You may have palpable masses, so you can imagine as the liver is going from maybe a single cyst in an otherwise normal looking liver to more and more cystic, that right under the skin surface, you can feel the cysts, and those are liver cysts generally that you can feel. And then there's an increased risk of leg swelling, of ascites or fluid filling in the belly, of hernias in the abdominal wall or in the umbilical region or inguinal region. And as there are more cysts present, there can be an increased risk of cyst infection. And then there are some other rarer complications as well. And I think one of the things that we really focus on for people when they have complications with liver cysts is just how to manage the pain. And there will be separate talks about this as well, but I think it's worth just reviewing here. The first thing in managing chronic pain is thinking about non-pharmacologic therapy, so behavioral modification, physical therapy, regular exercise, things like that. And then before moving on to pharmacologic therapy, which may be things like Tylenol or Tramadol, Ultram, and then really reserving opioids for the very last in terms of pain management. There are then more invasive therapies. And then if you look at the liver-related therapies, this could be something like a celiac nerve block, where you go in and you inject the nerve that manages the pain sensation coming from the liver. And if you can do a nerve block there, you may make a big impact in terms of managing the pain. And then more invasive therapies here that are related to the liver include things like liver cyst fenestration, where you go in and either drain or puncture the cyst, to things like partial hepatectomy or liver transplantation. So these final things, the partial hepatectomy, which means cutting part of the liver out, the cystic part of the liver, or liver transplantation, are really reserved for very specific indications. So here, what I'm saying is cyst burden, where the cysts are and how many of them there are, determines the best type of therapy. So now in this image, what you're seeing here is the liver. And in this particular image, these darker areas are the cysts. So here's a liver, and you can see most of the cysts are in this one side of the liver. If you look at this, you can see that this person has one very large cyst in the liver here, but the rest of the liver looks really pretty good. And that's distinctly different from this person who has a lot of cysts in the liver. This part of the liver looks fairly normal, but it's sort of a remnant compared to everything else that looks large and cystic. And then in this person, it's very hard to see normal and liver architecture because there are so many cysts. So this patient would be a good candidate for cyst aspiration and or sclerosis, where we would go in with a needle, we would drain the fluid out of that cyst, and then either leave it at that or put some kind of material in there to help the cyst from reforming. That's the sclerosis therapy. And they are doing some studies looking at foam sclerosis. That's a study that the Mayo had been doing. Here, the treatment would be to remove this part of the liver, so to do a right hepatectomy. And the liver does regenerate. So the idea here is you're taking out the part of the liver that has the most cysts to bring some relief. And in this case, there's really nothing to aspirate, right? All of a few very large cysts. There isn't a single section to take out. So this patient would be a candidate for liver transplant. And for people who are coming up to being listed for transplant, for those exceptional people who also have very large livers, there's something called MELD exception points for polycystic liver disease. And what this means basically is if you have renal failure or are on dialysis currently, and you have a very large liver with symptoms, with diffuse cysts, with very little remnant liver left, then you can be listed for MELD exception points, which means that you can make more points on the list for the combined kidney liver transplant. And then for people who are really not candidates for invasive surgical therapy, we do think of treatment with medicine. So there's one medicine that has been improved. These are called somatostatin analogs that help shrink the size of the liver cysts. And this is pooled data from 3 trials looking at this for people with either AD-PKD or AD-PLD. And the take-home message from these pooled studies is this, that the somatostatin analogs may be most effective in young women under the age of 48. One of the blood markers called alkaline phosphatase may predict who responds. So if the alkaline phosphatase is high, that might be a signal that that person is likely to respond to therapy. And then after the drug is stopped, the liver growth resumes, but there may be some lasting response. So that's something really to follow up on. And really for people who are very uncomfortable, who want to try this, you know, we sometimes say, let's try a limited trial of the therapy. And if there's no improvement, to stop treatment at that point. And then this is really just a final wrap up to show how we think about liver cysts now. So for someone who has polycystic liver, has a polycystic liver because of AD-PKD, we would discuss use of estrogens for the appropriate person. We would see if there are really symptoms that correlate with the liver cysts. And if they are, is there a single dominant cyst that can be aspirated? If the answer to that is no, are there multiple large cysts that maybe can be fenestrated, just sort of opened up to let drain? And if the answer to that is no, and the person really does have a significantly impaired quality of life, then perhaps a liver transplant is indicated. If they're either too sick or there's some other reason that they can't get the liver transplant, then that's a person then who might benefit from the somatostatin analogs. And I'll go through more of that tomorrow when I talk about the liver issues in more detail. And with that, I'm leaving you with a couple of pictures of our PKD walks when the walks were in person, and hopefully they will be again soon. Thank you.
Excellent. Thank you for those great presentations. All right, and we are out of time for questions, but So thank you all so much, and enjoy the rest of your day.